Good afternoon to everybody. My name is Luigi Fontana. I'm chairman of the Department of Ophthalmology at the University of Bologna, Italy. And it's a pleasure for me to present the application of intraoperative OCT to corneal lamellar surgery. Now, I may assume that you are interested in cornea transplantation. And the first question I ask you is whether you have an OCT applied to a microscope in your operating rooms. So what I'm going to do is to try to convince you that OCT, intraoperative OCT, is not a waste of money, is not a waste of time, but is a real revolution in terms of surgical application for aiding a cornea lamellar specialist, and not only those. Now, what we normally see through a microscope is actually this. This is coaxial light illumination. And so when we look through a microscope and we perform a capsular axis, basically we use only the X and Y spatial resolution. And the quality of our vision is dependent on optics and illumination. Okay? And needless to say that Leica microscope provides excellent optics and illumination if you had a chance to try this microscope. Of course, when we do, for instance, a sculpturing of a cataract, okay, we not only use X and Y spatial resolution, but we add also another dimension, which is the depth. So we put in the game also the Z space, okay, resolution, which is something that also relies not only on optics and illumination, but also on our stereopsis. So our capability of perceiving the third dimension. A completely different cut of fish comes when we put the integrated OCT in the game. And this is exactly what happens. So on your left, you have the ordinary coaxial light illumination. And you can see that I'm dissecting through the cornea. But of course, I do not know the evenness and also the thickness of the layer that I'm leaving behind. But if you look at the OCT image, simultaneous, you can see that the layer of the cornea that I'm leaving behind, so basically the recipient bed, is very thin, very smooth, of the quality that we want in order to provide a final outcome of pristine vision for the patient. So if you only had the image on your left, which is what we normally have in our microscopes, you wouldn't be able to say if the layer that I'm leaving behind is thick, thin, irregular, or regular. But if you look at the image on the microscope, on the OCT, you immediately know that I'm lifting up a layer of stroma and I'm dissecting through and leaving behind a layer of cornea, which is very even in thickness and very regular. Okay? So this is another dimension from the previous three that I illustrated you. Okay? Now, what is OCT integrated to a Proveo microscope? And you can see that basically on your left, those are the optics of the Proveo. And here is the integration of the OCT right in the middle. And here is another example of an integration of OCT from a competitor. And you can see that there is a huge difference because the OCT beam doesn't go through all the optics, but it remains basically limited here, whereas For the competitors, it goes through the optics here, but basically only one channel, okay? So that is a major limitation. So what are the benefits of the Proveo OCT integrated? Well, first of all, there is a large field of view. If you had a chance to use the Proveo, you have already appreciated that. There is a center uniform beam path, very precise measurements, which are provided by the calipers. There are a unique element with a, which is, thanks to the Proveo, is not actually available with other microscopes. And there is an independent zoom and focus. And so basically is an upgrade of the current Proveo OCT. So you may or may not believe that an integrated OCT could actually be a benefit for your surgery. So I may assume that you are the major skeptics in the world thinking that an OCT is a waste of time and a waste of money. Okay? Let's assume this. You of course know about hydrop. This is a keratoconus evolution, and at a certain stage, some patients may develop a hydrop. Okay? And I'm presenting you the treatment of a case of corneal hydrop in a keratoconus patient that we did not want to operate by doing a keratoplasty. And the reason is because this patient is the only eye patient, okay, and had a bad experience with the previous keratoplasty in the other eye, and we didn't want to do a keratoplasty in this case. But of course, we wanted to solve the problem with the hydrop, okay? And you can see from the OCT, then the Descemet membrane is detached here. And so the solution for the hydrop is only to bring this layer back to the cornea, okay? And there are basically two possible solutions in general terms. One is to let it go and see what happens. Oftentimes, this patient get better by themselves, but oftentimes they don't, as in this case. And of course, there was an urge for the patient to regain his vision because he's the only eye patient, okay? And the second solution could be to put a gas bubble or an air bubble inside the eye, inside the anterior chamber, and bring this layer back attached to the posterior stroma. The third solution, of course, is to do a keratoplasty, things that we didn't want to do, okay? So let's see how we tackle this problem. So this is intraoperative OCT, and we can picture very well where the detached Descemet membrane is, right there. And so we did a paracentesis in order to put an air bubble inside the anterior chamber, okay? First of all, we did an iridotomy inferiorly because we didn't want to cause a pupillary block in this patient. And you can see that even through an opaque cornea, you can see that the iridotomy is patent. Then we put an air bubble inside the anterior chamber, but nothing happened. Descemet membrane remained the same, detached. So I put a larger bubble inside the anterior chamber, and nothing happened again. There was still liquid there, not reabsorbing. So I took an MVR blade, and I went through the cornea, and you can see the MVR blade here, moving right where the space between the Descemet membrane and the posterior stroma is. And then I remove the MVR blade and allow the liquid to escape from that space. And the Descemet membrane became attached. Now the question is, would any one of you been able to do the same without an OCT? Is this enough convincing you that this is a major add to the quality of your surgery. This to me is a major demonstration that something that I wouldn't be able to do without an OCT, now I am able to do thanks to the high quality resolution of the Proveo OCT. But you may not believe that this is enough to convince you to spend this amount of money. So I'm showing you another case. This is a post-infectious glaucoma. Very common thing to see, okay? This patient had a contact lens infection related and developed opaque cornea. Can't see a thing, okay? What we want to do in this case is to do a lamellar keratoplasty, okay, potentially. But of course, we don't know if the scar is deep enough or deep not enough to allow you to perform a keratoplasty, a lamellar keratoplasty. Because if it's full thickness, it's unwise to do a lamellar keratoplasty in these cases. So how do we proceed? So this is a preoperative OCT showing that over there, maybe it was full thickness. And this is intraoperative OCT, and high quality showing that maybe there is space between the glaucoma and the deep stroma. So I perform a partial thickness refination, as I do for lamellar keratoplasty, and then I excised a layer of cornea. And here is the result. You can see through the OCT that the stroma, the deep stroma is actually clear, and I can perform a deep anterior lamellar keratoplasty by a big bubble technique. And this is the injection of the air in the deep stroma, formation of a large bubble, and this is slashing the bubble, the Descemet membrane comes back, and I excise the stroma and leave basically the pre-Descemet layer exposed, and I put a layer of donor stroma on top. Okay? So, the story is that without an intraoperative OCT verification, I wouldn't be able to do a lamellar surgery in this case, because my preoperative assessment was actually telling me that there was a full thickness glaucoma. But because you can double check this intraoperatively, then you can change your mind as the surgery goes in order to try to do what you planned or what you wanted to do from the beginning. So this is another plus that otherwise you don't have if you cannot use an intraoperative OCT. Now let's get more into the details of lamellar keratoplasty. Of course, you know that we're going to talk about stromal replacement, selective, and stromal endothelial replacement. For stromal replacement, the indication is whenever the stroma is opaque and whenever you have an healthy endothelium, okay? You know very well that. And you know that the most practiced procedure in the world is the Mohammed Anwar big bubble technique, okay, that we normally perform by injecting air deep in the stroma and by causing detachment between the pre-Descemet layer and the stroma. That is something that we've been doing for quite several years, probably since 2003, but the main problem with this technique always was that we didn't know whether the air was injected deep enough in the stroma, whether the cannula was placed deep enough in the stroma, whether the needle was placed deep enough in the stroma in order to get the big bubble formation. You know that very well if you had experience with this technique. So what does the OCT provide in terms of aid for a DLK. First of all, allows you intraoperatively to assess the corneal thickness in order to establish, how deep should be your trephination. Then it allows you also to assess whether the trephination was deep enough or deep to the level that you planned, and also allows you to guide the cannula inside the stroma, evaluate the position of the cannula, evaluate the big bubble extension, and also evaluate the completeness of the stroma removal and also the donor host position. I'm showing you all of this, okay? So this is assessment of the cornea and anterior segment architecture. Is done by intraoperative OCT, and this is excised in a donor cornea. It's very simple. You can measure with calipers the depth of your trephination. Here is. You can see that I can put the caliper to measure how deep went my trephine, okay? And I can increase the deepness of the cut if I wanted or if I have to. So this is a major advantage, okay, that otherwise we wouldn't be able to do, okay? Then, of course, you may use the OCT for guiding your cannula through the stroma. And you can see very well the position of the cannula here in one of the sections, okay? But I'm showing you exactly what happens. So I insert a relatively sharp instrument to create a tunnel, and I can measure whether my tunnel was deep enough from the Descemet membrane. In this case, was deep. So I insert my cannula, and you can see the cannula advancing here, and you can see how close it's actually to the Descemet membrane. So you do see what it does, okay? And once it's deep enough, you inject air, and you get a bubble formation which much higher probability that without using an OCT, just by guessing where you are in the stroma. And why depth in the stroma is important is because we know that if you're very close to the Descemet membrane, your chances of having a big bubble formation is very high. Vice versa, if you're not deep enough, you are far away from the Descemet membrane, chances of getting a big bubble formation are far less. So that is relevant for the success of your procedure. So what happens in the real life? So I showed you a few examples from donor cornea, excised cornea, okay? But what happens in the real life? So this is the case, as I probably did, a few months ago. So I insert, the cannula deep in the stroma, and I measure exactly where I am. I can picture where I am in the stroma. And once I'm happy with the depth position of my cannula, is only 78 microns from the Descemet membrane, I insert my cannula inside the stroma and I inject air. Here is a cannula. And here is a big bubble. Okay? So you can picture exactly what you're doing and where you're doing. Without an OCT, you wouldn't be able to do that. Okay? So then I proceed, of course, excising the stroma, and I can now open the big bubble, okay? And I cut away the stroma from the donor, from the recipient, and check whether the surface that I created is very smooth and is also very even in thickness, okay? Then I put a donor on top, suture it as usual, and double check whether the attachment and adhesion between the donor and the host is complete. So at the end of the surgery, thanks to the OCT, you know exactly that you leave the patient with a fully attached Descemet to the stroma. Okay. So there are less surprises on the following day on regards of whether you know, you may have a double chamber, things that you really don't want to have. So here are some examples, okay? This is after the big bubble formation on your left. You see that the layer is very smooth and very regular. And here is after placement of the donor lenticle on top. And you can check the adhesion between the pre-Descemet layer and the donor. By doing a raster, you can check the regularity of your surface, and also eventually you can check the complete adherence between the donor and the host at the end of your procedure. Now, this is another case. This is a case where big bubble is not possible. It just doesn't happen because there is a full thickness glaucoma in this case. Again, another post-infectious keratitis. There is a full thickness glaucoma. We know that we cannot achieve a big bubble, but we want to do a deep anterior lamellar keratoplasty. What is the advantage of the OCT? So I perform as usual my partial thickness refination, and I inject air anyway in order to cause an emphysema inside the stroma. And why is that? Is because when the stroma becomes white, whatever is white is stroma, whatever is not white and transparent is a Descemet membrane. So I can recognize where I am, okay? So here is air injection. I do not want to, or do not pretend to achieve a big bubble in this case. I just use air as a dye in order to create this emphysema. So I cut down, and you can see the dark reflex coming from the iris, showing me that we are deep enough in the stroma. And by excising, as things go by, you can actually check at the OCT whether the layer that you left behind is thick or thin. And in this case, it's very thin, at the same level of thickness of the one that I achieved with the big bubble. So the optical quality of the bed that I left behind should be the same of a big bubble once it's achieved. So this is another application, probably very meaningful, showing you that by using an OCT, you know exactly the thickness of the layer that you left behind and you want to preserve, okay? Otherwise, it wouldn't be possible. Now, another form of keratoplasty is a mushroom PK. Mushroom PK is performed when deep anterior lamellar keratoplasty cannot be performed, and the endothelium is spared because your full thickness part is only 6 millimeter, and the anterior part is very likely 8 to 9 millimeter. And we normally perform it by doing a two-piece mushroom created with microkeratom. I'll show you a case. So we perform a partial thickness refination, about 300 microns, remove a layer of stroma, and once the layer of stroma is removed, then we perform a central thickness, full thickness refination of 6 millimeter. We mark the refine, and we perform a full thickness refination. We remove the diseased part of the deep stroma and endothelium by scissors. And here we are. And then we prepare with a microkeratom two pieces. One is 6 millimeter stroma and endothelium, and the other one is 9 millimeter just stroma. And we place the two layers there. And with the intraoperative OCT, we check whether the layers actually totally attach one to the other. Okay. Now, this type of adherence is very important because if the two layers do not adhere, the following day you have an opaque cornea. And you have to bring the patient back to theatre, put another big bubble, put another air bubble inside the anterior chamber, and make them to attach. But with the intraoperative OCT, you may be 100% sure that the layers are actually perfectly attached. Now, how about endothelial keratoplasty? How could the intraoperative OCT be obeyed for a DSAEK or a DMEK? We all know that in terms of DSAEK, the quality of the donor is absolutely fundamental in order to achieve a good result in terms of visual acuity. And the quality of the donor has to be that the donor must be very thin, less than 100 microns, and very regular. On the bottom is another example of a donor which was cut not in the proper way, so that over there is relatively thick, but over here is very thick. So it's like a kind of a wedge shape, okay? And this probably is not compatible with a good visual outcome, whereas this one is very compatible for a good visual outcome. But how do you know when you cut your donor, if you do cut your donors in the operating room, whether you have achieved this situation or this situation? You cannot. But if you have an intraoperative OCT, here is an example of a donor placed on a microkeratom, and you can measure the thickness of the cornea intraoperatively, cut the donor, and then measure again the thickness of your donor and the quality and regularity of the thickness all throughout the cut. In this case, it's very regular, and in this case, the donor can be used, okay, safely. In a situation of a very opaque cornea, intraoperative OCT allows you to guide and visualize the donor DSAEK lenticle as he actually dragged and placed inside the anterior chamber, as in this case, okay? And most of all, you can actually see the opposition between the two layers. In this case, I'm massaging the cornea in order to remove this fluid, and at the end, I do a raster and a scan, and I can be 100% sure that the two layers are perfectly adherent, okay? So this is another add to a DSAEK procedure. Now for DMEK, what could be the potential advantage? Of course, I do a Descemet, but oftentimes when you do a Descemet, it doesn't come regular. You may leave some remnants of the Descemet membrane in place. Things that you do not want, because that causes irregularity, okay? And by using an OCT, I can do a scan, and I can double check if there are remnants of the Descemet membrane left behind that eventually needs to be removed before you introduce your donor lenticle. Donor lenticle that has to be placed in the correct position and not upside down, of course, in order to achieve good results. But how do you check whether the donor is upside down? You know that the donor wants to coil internally in order to be in the proper position, but sometimes it does coil the opposite way. And you know that in that case, of course, the endothelium is not placed in the right direction. So I introduce my donor, okay, and I double check with the intraoperative OCT the coiling of the donor. And you can see in this case that it's coiling in the correct orientation. And once it's that, and once it's actually unfolded, then you're sure that you can inject air or gas as you prefer in order to achieve the best result. So here you can see the coiling, which is actually facing upward, okay? And you know 100% that is actually the orientation of the donor is correct. Now, the latest introduction is the artificial endothelial membrane, the EndoArt. You probably heard about. Okay, EndoArt is a piece of plastic, acrylic, that may replace the endothelium in cases where there are little chances that a human donor endothelium may provide a long-term result for complicated cases. Okay, here is an example. The EndoArt is placed on the cornea, correct orientation, introduced inside the eye, and once it's there, spontaneously unfolds. And then what you do is actually you elevate the implant to adhere to the posterior cornea. But how can you be sure that this adherence is actually achieved? Okay, again, by intraoperative OCT, you can see that there is a gap between the posterior stroma and the donor and the implant, and by removing the liquid behind in the interface, then you can be sure that you have achieved complete adherence between the two layers. Again, you wouldn't be able to assess that without an intraoperative OCT. Okay. Showing this again because you probably haven't seen them many times. Here it is. And by scanning, you can see that there is no liquid behind the two surfaces. Okay, this is about it. Have I convinced you enough that intraoperative OCT for corneal surgery transplantation is useful?